All right, we're going to go ahead and get started with today's webinar. So I'd like to welcome you all to the ninth in our series of 10 webinars that our office, the Oregon Office of Rural Health, is hosting, focused on critical access hospital finance and operations. Today's webinar is the No Surprises Act, Protections and Transactional Compliance. I'm Sarah Anderson, and I'm the Director of Field Services at the Oregon Office of Rural Health. Next slide, please. Thank you. Before we get started, I would like to go over a couple of logistics. The audio has been muted and the video's off for all participants. Select the ellipses on the right of your screen to populate the chat feature. That's what we're going to use primarily for you to ask your questions. We'll monitor those questions as we go throughout the webinar and ask them of our presenter either during the webinar or at the end. You can also raise your hand at the bottom of the screen by clicking on the little hand button, and then we can unmute you so you can ask your question live. The presentation slides and recording rather, will be posted shortly after the session on our website at the link on the slide, and I'm going to put that link in the chat in just a moment. Next slide, please. So as I mentioned a moment ago, this is the ninth, the second to the last in our series of 10 webinars that we're hosting with a focus on CA finance and operations. You'll see the last webinar for this year listed on the slide, and you can find more information on the ORH website with the link I'm adding in the chat in a moment. Next slide. And with that, I'm really pleased to introduce our speaker. With us today is Rob Bloom. Rob is a principal at Wintergreen, and before joining Wintergreen, he served as the CFO for Carthage Area Hospital for over a decade. He previously held positions with the hospital as Administrator of Primary Care Services and Interim CFO. In addition to his role as CFO at Carthage, Rob also concurrently served as CFO at Claxon, Hepburn Medical Center, and Orleans Community Hospital, in addition to providing consulting services to several other hospitals in rural New York. Welcome, Rob. We really appreciate you being here to share your expertise, and I will turn it over to you now.
All right. Well, thank you very much, and welcome everyone. I appreciate you taking the time to join us this afternoon to talk about the No Surprises Act. This is one that's going to be, I think, a little bit of a challenge for us, as in many cases, we're going to be not necessarily building the airplane while we fly, but definitely making repairs to it while we're flying. And part of the reason for that is, everyone is still sort of trying to sort out what this looks like from CMS to the various changes that are coming down. And of course, we have the interesting challenge of compliance with a retroactive date. And so with that, I will jump right in. And so this really came to be as part of the Consolidated Appropriations Act of 2021. And it introduced new requirements for providers to ultimately, the goal here was to protect individuals from surprise medical bills. So within that, there are a few key areas that we're going to spend some time focusing on today. But it prohibits us from directly billing individuals for the difference between what we charge and any amount that the individual's plan would have had, plus the cost sharing. So in essence, right, balance billing is the common language term we have there. It introduced a requirement for us to provide a good faith estimate of charges for care to the uninsured, and to be able to also, for those that are commercially insured, to submit good faith estimates to the individual's plan or insurer. It created a new patient provider dispute resolution process where our customers can essentially contest any charges that were substantially in excess of that good faith estimate. It requires us to publicly disclose these restrictions on balance billing, which, is just one more disclosure we have to make sure that we have out there. And it limits billed amounts in situations where there's been a network status change mid-treatment, really with the goal of protecting the consumer here. And so essentially that means, right, if we stop participating with a particular insurance plan, we still have to make sure that we provide continuity of care for that patient. So as I mentioned, this really went into effect January 1st of 2022, and it really applies primarily to those that either do not have insurance or have commercial health insurance coverage. And the reason it is really limited to those groups is because people that are enrolled in Medicare, Medicaid, VA, TRICARE, Indian Health Services, things like that, they typically already have built-in protections. So this was really just expanding those governmental payer protections to the private market. So, the types of things we're looking at are employment-based groups, both self-insured and fully insured. So that's just your typical business, school, etc., in your community that's providing health insurance for their employees. Individual or group health plan coverage that is coming from one of the exchanges, your federal employee health benefit plans, any non-federal governmental plans that are sponsored by your state or local government, certain church plans, and student health insurance coverage, which is really, for kids going to college. So one of the main themes that you're going to see here is, as we go through this, is the need for a team-based approach. And part of that is because this touches so much of our operation and the ways in which we need to carry this out. But additionally, it's going to touch on several other obligations that we already have. And I think that's one of the key takeaways I hope that everyone has, is this is going to be a big lift, even though it may not necessarily be a large number of instances that we have to deal with in terms of people challenging us, but certainly our obligation is going to be there for a large portion of our populations that we serve. So under continuity of care, basically what this is requiring us to do is that if we cease to be an in-network provider because of termination of a contract with an insurance carrier, we have to provide certain protections for an individual who meets the definition. So one of the things we're going to have to figure out how to do is how are we going to notify each individual enrolled who meets the category of a continuing care patient. We're going to have to provide the individual the opportunity to notify their plan that they need a transition of care, and then we're going to have to permit the patient to continue to have the same benefits that they would have had under that plan, under the same terms and conditions that would have applied for a period of time. And that is going to be either the earlier of 90 days or the date on which the person is no longer a continuing care patient with the facility. We have to have a provider directory that is kept essentially complete. And so what's going to happen if we don't do that, we're going to have to refund enrollees amounts that were paid in excess of in-network cost-sharing amounts with interest. And take special note of that because that's going to be a project. If they were inadvertently billed out of network due to an error on our part, we're going to have to maintain business processes to submit provider directory information at specified times to support the plans. And that's because the health insurance plans have obligations under this regulation as well. And then we are going to also have to make sure that we document and the plans take care of keeping everything up to date, right? So removing a provider from their directory. And then at that point, then the plan will have to bear the financial responsibility for providing the inaccurate information. So, this is something where we have actually some shared goals with the insurance carriers. We have to provide public disclosure of the regulation. And so, again, you'll note both healthcare providers and healthcare facilities. We have to provide those disclosures distributed through multiple methods and outlining the key protections. So it has to include information on prohibitions on balance billing for emergency or non-emergency services with which we have to comply. That is to also include any state laws that may govern balance billing, which can vary by state. And then contact information for state and federal agencies that the individual can contact to report a suspected violation of these protections. And then we have good faith estimates and the provider patient dispute resolution processes. So we are going to have to make sure that we're able to provide good faith estimates ahead of time to individuals that do not have health insurance. And we have to make sure that it's going to be a relatively accurate estimate. And that's where that good faith part comes in. It doesn't mean that it has to be a perfect estimate. Everyone recognizes that sometimes the unexpected happens, particularly you think about things like in the surgical arena. But those really have to be unforeseen based on kind of the reasonable person standard. And then we'll have the patient-provider dispute resolution process that is outlined in quite a bit of detail within the regulatory guidance on how, if patients have an issue, how we're going to work to resolve that. And essentially, we're all required to do this as critical access hospitals. There's really nobody that's left out of this that has any sort of deeming process that's required for their designation. All right, so how are we going to take care of our revenue? So again, as I mentioned, kind of one of the key takeaways here is that we're going to have to create an interdisciplinary team that meets regularly to figure out what our processes are going to be to make sure all of this is working together. So when we think about continuity of care, we have a number of things that need to be accomplished here. The first step is we have to figure out who are those patients. And the reason you'll see up top there, we have so many departments involved, right? It's not just as a simple process of, trying to go into our business office tables and run a report based on, okay, who do we have that had this particular plan that, we may no longer participate with. There's then also the clinical side of figuring out how are we going to identify those patients for which we have an obligation to provide continuity of care. We need to be thinking as we are sending information out to those patients, how we're going to stay compliant with other related regulations such as HIPAA. And it's going to require us to work proactively, with our clinicians, patients, and the plans to ensure a smooth transition. And we'll try to leave, a pretty decent amount of time at the end here for questions, so that we can try to make sure we get to, every question that folks may have. Then we move into the provider directory process. And again, you'll see the exact same, suggestion around creating that interdisciplinary team. But this really goes to, how are we going to make sure that we're doing a really good job of making sure that all of our information is communicated with our third-party payers. And so if you take a step back and think about that, how how often does it come up, right, that we have an issue within our credentialing process as part of our revenue cycle? And really, this is going to highlight any of those challenges that we have. So when we're thinking about the provider directory process, that's going to have to run in lockstep with the processes that we have set up for credentialing. And again, that's not simple and straightforward, right? Oftentimes, you're working with a payer and on their platform, trying to get your providers, your services, all of that out there properly. And sometimes it just doesn't happen that way. So it's really going to be incumbent upon us to set up those regular meetings with the plans to make sure all of our providers are reflected appropriately. And of course, one of the benefits of improving that process is it should become easier for patients to find our services as well. We're going to need to set up some form of automated process to flag potential balance billing situations for review. So what we're talking about there is, anytime we have a statement going out to a patient, we're going to need to try to find a way within our billing software to flag any place where we're balance billing based on the way in which the claim was adjudicated, and at least get some eyes on it to make sure we don't have a potential issue being set up here. And finally, again, we're going to have a process to identify those potential patients that may have been impacted by provider directory issues so that we can go back and make sure that the billing is compliant. So as you start to kind of, peel the onion on this thing, it becomes pretty apparent that this is not, a quick and easy solution for anyone to put into place, and that it's going to require the skills from a very large complement of our employees, that it's really going to take a lot of expertise to make sure that we have this all set up properly so we don't find ourselves in a difficult situation. Required disclosures. Again, this just becomes one more thing that we're going to have to be thinking of. So it has to be on a sign posted prominently at the location. So, one recommendation would be to make sure that it's, next to your HIPAA and privacy notices or charity care notices. So as you're going around to your various locations, you make sure that all of that is just in the same spot. It makes it easy for us to check and audit. The No Surprises Act notice has to be provided to all of, again, our insured commercial patients, regardless of their network status. So we start to think about, how are we going to build this out as part of our registration routine? And then secondarily to that, just start to try to think about, the amount of time that, each little thing we keep adding to the registration process does to our workflow. And we certainly want to make sure this is something that, doesn't slow us down too much, such that we start to have other issues. But also, think about things like, how is your, registration quality process running? Right? If you select the wrong insurance, and you've built this into your registration routine in an automated fashion, you potentially set yourself up for another failure here. So that's another piece we have to be thinking about, how we're going to monitor that as part of our existing registration monitoring processes. We have to provide the notice in person, through mail or email, as selected by the patient. So, again, we start to think, how are we going to document that we're going, the patient's election here? So again, that is our suggestion, is, try to find a way to build this out as part of the registration and follow-up routines. Because we do have, a time window here in which we can do that. And then we have to make sure that notice is furnished for each episode of care. So we have to get the patient's written acknowledgement of receipt, or it is not required, but we need to have it, right? How are we going to prove this so that we can demonstrate compliance? So the good faith estimates process. And what concerns me here, right, is when we think about just the challenges that we have had as an industry in being able to comply with just some of the pricing transparency requirements. Um, this really is taking it to another level, and I get concerned, particularly for those facilities that may not have um, as robust of a process for the way in which they're charging for various complex procedures. Um, if you think about an office setting, it's not particularly difficult for most of us to provide some form of good faith estimate. But when you start to think about, anything that's happening in the operating room, it gets a whole lot more complicated for us to do that. And so, depending on how our charge capture process has been set up at our hospitals can have a pretty significant impact on how well we're going to be able to perform the good faith estimate process. Um, and so again, one of the things that we need to be thinking about here, just for compliance, is let's make sure we have a good process to identify the uninsured individuals, so that we can make sure, again, we can have an audit process in place to check how well we're doing with it. Um, we need to make sure we're able to manage the required notice delivery. Um, there's a process here, right? As we go through the steps, we have to determine who the convening provider is, right? Is it one of our physicians? Is it another physician? Who has the obligation? Do we share the obligation? Then we have to calculate and deliver the good faith estimate. And again, make sure that we retain that documentation so that if we end up in a dispute process in the future, we know where we have a defensible position that will hopefully lead to a better outcome as we try to, walk our way through these things. Then we get into the dispute resolution process, and this is an area that there have been, ongoing lawsuits that have been filed, and it's going to continue to evolve. Um, but really, this sort of wraps up everything that we've done prior to this part of the encounter. So by the time we end up in some form of dispute resolution, if we had a misstep somewhere along the journey before we got to this point, that's where we're going to have a challenge. Um, so if we do end up, which probably all of us will have at least a few of these, we want to make sure we have developed a process to aggregate all of the required information for the dispute, right? So as part of this, we send all of the information into that third party, um, which is going to include, the good faith estimate, a copy of the billed charges, and then really not all that different from any of our denials management processes we might already have in place with to deal with the various insurance carriers. We're going to make sure that we have documentation providing evidence for the difference between the good faith estimate and billed charges. Um, we want to make sure that we have a process in place to ensure that billing activity is suspended while we're in the dispute resolution process. So we are not allowed to continue to try to collect once this goes into dispute resolution. And one of the areas we want to make sure that we don't have an exposure is with regard to any outsourced partners, right? Whether that is someone who does, the self-paid billing on our behalf, or, think about the places where we, put anything that moves into a bad debt status, right? Oftentimes, you just think about today, you might trip across an issue with a bankruptcy, right? Where inadvertently, we failed to inform our debt collection agency that we needed to suspend it. Those same tripping hazards will exist in this scenario. Um, so it's really important as we're mapping all of this out that we think about all of those potential points of failure. We want to make sure that we have access to the online federal dispute resolution portal, um, and a process for complete submission, right? So what I mean by that is we need to make sure that someone is laying eyes on and essentially checking off that everything that we needed to be uploading, is complete, because we don't want to find out that we lost a dispute just because we had an incomplete submission. And then again, we're going to want to close the loop on these things as part of our existing denials management processes, right? So regardless of whether we had a good outcome or a bad outcome, we want to take some time and think about what takeaways we have from that. What did we learn? What do we need to change? And then again, go back and make sure that we educate staff. One of the things that we can be doing proactively right now is, cleaning up our provider rosters and providing demographic files to all of our payers to make sure that everything is squared away. And then also when we onboard new providers, we need to make sure that we have a process in place for a couple of things to happen. One is that they either not see patients, which is financially a challenge for us, right, until they're fully participating under the contract, or that we have set up internal controls to prevent billing, right? So, um, it's just one more challenge for us in a space that we've had a lot of issues already to deal with. All right. So in terms of kind of key action items, right? So I mentioned before, we need to be very mindful of the interplay between any of our existing processes and all of these new No Surprises Act requirements, because there is going to be a ton of overlap. Teamwork and the processes that we set up are going to be the key to making sure that we are compliant here. And we also need to make sure we're always keeping an eye on the number of lawsuits that are out there that have challenged the rulemaking, particularly with regard to the independent dispute resolution process. And again, there are, a number of, places we can get that information, right? A simple occasional Google, or I'm sure, most people get the emails out from Becker's, but we need to make sure we take the time to sort of scan the topics and look for anything that might be impactful here for us. And then we really need to think about what's going to happen from a cost standpoint if we fail to ensure compliance, right? So obviously the penalties are out there, but one of the things that I see as one of the larger cost risks is that providers that don't have well thought out processes early on are going to end up adding staff as a way to try to create quick fixes for this. And that's never really a good long-term solution. And the other challenge we need to be thinking about is that there might be some slower throughput in key areas of the revenue cycle, and a lot of this, of course, is going to be driven just based on each hospital's payer mix, right? So for those hospitals that have larger numbers of uninsured or commercial patients, this is going to be a bigger lift than, say, if you have a hospital that is much larger, more largely skewed to your federal or governmental payer classes. So a number of things that we need to make sure we're thinking about as we walk through this. So with that, I will pause for any questions.
Thank you so much for sharing all that information with us, Rob. As a reminder to folks, please either enter your question into the chat feature at the bottom right-hand side of your screen, or raise your hand and we'll ask a question of Rob, or unmute you so that you can ask a question of Rob. I do have a couple of questions. The first one is related to a point that you made on the last slide regarding lawsuits in relation to the No Surprises Act. Can you talk a little bit about what you're seeing and what impacts those lawsuits may have in the future?
Sure. So, there have been a number of lawsuits lodged either by, systems or, medical associations. Um, so I think the most recent one that I saw that came out, I think actually even this week, um, was that the Texas Medical Association won a lawsuit with regard to what was kind of deemed the method, it impacted the methodology by which people would use to, calculate qualifying payment amounts and, what they call ghost rates. So there's a lot of things happening around just how it's going to be calculated. So in that particular case, the lawsuit was basically arguing that this law tilted the table in the insurance company's favor, um, because it makes it challenging. They have more information, right, ultimately than what the hospital has in some cases. And then they've also, had some wins around just, surely the cost that everyone would have to pay for the dispute resolution process. So, that's one. There have been a number of other lawsuits where, CMS actually won. So, it's changing all the time. And then as soon as there's that process, right, you may or may not get an appeal, you may get a reversal. And then you also then get subsequent CMS rulemaking. And again, part of the challenge is, we were all obligated to comply with this before CMS even released the final rules. So, I think right now the biggest thing we can do is, try to comply as best we can. And we're going to have to spend a lot of time ultimately going to the CMS website as well to keep track of it.
Good, thank you for that. Another question that I have, you talked a lot about teamwork, which it sounds like is very important in the context of making sure all processes and policies are in place. And I was wondering if there is a resource somewhere that you know about that have example processes in relation to the No Surprises Act that folks could use as a resource as they're thinking about and or developing and updating their own.
Well, I think one of the challenges that comes with this is in many cases it's going to be very entity specific, and the part of the reason I think for the team based approach is we all have different EMRs that even there's not necessarily a consistent installation of any EMR, so you have a lot of variation out there. And everything we've done up until this point, without knowing it, is going to impact the ways in which we can gather information and develop processes around it. Um, and so there's going to be a lot of, variation, right? Are you a standalone facility or part of a health system, right? What resources are available? There's just going to be a lot of variation. I mean, I think there are some things that seem straightforward, but maybe aren't, right? So even the things that I've recommended that folks might build in as part of their registration process, right? Depending on your EMR and what you have available to you is going to change how you're able to do that, right? So if you've got something that's robust, right, and maybe somebody picks the right insurance on the drop down, you can have the form auto generate and help, and then you can build those uh, protections in place that don't allow your registration clerk to advance past that until they've gotten that taken care of. But you have others that just aren't going to have that capability and are going to have to come up with some other process. So I think there's going to be just a lot of variation by provider. And that's why I really recommend getting that interdisciplinary team together to figure out how we're going to do this.
Great, thank you so much. Another question that came in from a hospital. Are we required as a hospital to send the provider directory several times a year? For example, every 60 days, once a quarter, or only when the hospital makes a change?
So, it's really just when there is a change, but I'll caveat that with however. The question is, how are we going to capture all of our own changes? So if we were in a room and not virtual, what I would say here is somebody raise their hand if they've never had a credentialing problem. And I'm guessing that not very many would go up. And so what we start to think about is, first of all, how do we make sure we're capturing all of these changes, right? It may be very good, for instance, here to make sure that we have, whoever does our med staff credentialing, because usually that does actually get done pretty reliably, at the table to alert us to new providers, or maybe it's human resources, whomever has that first touch for change. But also then remember, it's not just that we have told them. One of the places I don't think we want to be is in the sort of situation where it's finger pointing back and forth between us and the plan of who made the mistake. So, when we put our providers out there, right, did they show up properly as what they were and everything they were doing for us? Or did we sort of put them in one bucket but not another, and somehow that gets us tripped up? I think that really is one of the challenges we need to think about. And a lot of that you can do by essentially trying to, go to the payer websites and essentially shop for your own services, right? Do you find your providers where you expect to find them?
Thank you so much. Rob, I don't see any other questions in the chat or any hands raised. So let's move on to the next slide, and we'll give folks a little bit more time back in their day. So I have a few announcements, but before I do that, when you close out of this webinar, a survey will automatically pop up for you to take, and we encourage you to take that so that we can provide these types of webinars in the future with topics that are of interest to you. And there's also the opportunity to receive CE credits for attending this webinar today. So in terms of announcements, the next webinar that we have with the Wintergreen team is on September 14th. This is our last one for this year. Our year runs through September, so we'll be starting up another series in a couple of months, but that one will be Fund Your Mission, Practice Steps to Move from Volume to Value. And the link on this slide is live in the PDF that's posted on our website, and I'll make sure that you receive the slides with the live links in them as well so that you can register for the next one if you haven't already. October 11th through the 13th, our 40th annual Rural Health Conference will be held in Sun River. Registration is live. And we are really, really excited about this year because it is our 40th anniversary. We have lots of great content, and we'll have some different ways to celebrate throughout the conference. And one of those pieces is we're going to post printed vignettes of stories from rural health facilities and communities that really highlight successes and achievements that each individual community has made to improve health in their community. And we'd really love to have your story featured. There is a Tell Us Your Story link that's on this slide. It's a short form to fill out, and it doesn't need to be a very long story. We actually prefer shorter ones, and really encourage you to submit those for our conference. Next slide, please, Rob. All right, and I just want to thank everyone for attending today. I want to thank Rob for a great presentation. Again, the recording and the slides will be posted on our website very shortly, and I'll also email out the recording and the slide deck to everyone who's here today. Thanks so much for attending, and we'll see you again in September.
Right.